So good afternoon, good morning for those in the US. I'm Gila Tolub. I'm the Executive Director of ICAR Collective. I am super happy to have you here with us. And today, our webinar is called No Soldiers Left Behind. This session is actually a follow-up to a roundtable that we hosted September 29th in partnership with Momentum, and Avi Cirt, the CEO, is here to discuss how we could coordinate the care of discharged soldiers and the support to their family. It was a discussion that was very inspiring, but also a bit sobering, because we saw a lot of goodwill, a lot of innovation, but also a lot of fragmentation, especially during the transition from the military to civilian care. And so today we want to share with you the findings from the roundtable and some of the actions and ideas that came out. So the webinar is designed to be short and focused. We're going to start with Eyal, who's going to explain the latest data and explain, why we need to act now. And then we'll have a discussion between Avi, the CEO of Momentum, and Eyal, Professor Eyal Fruchter, who is the head of medical and scientific affairs here for ICAR Collective. And we will open the floor also for your questions during the discussion. So you can ask them aloud, or you can put them in the chat at any time during the conversation, and we'll look through them. So I think, simple idea is no one should fall between the cracks. So our work is about also working for the soldiers, for the reservists, for their families. So with that, I'm going to share my screen, and Eyal, you can take us away.
Sure. So I'm very happy to be here. And now that I've seen somebody he's here is from Milken. My daughter used to go to Milken. So in the year that we spend in LA. So I'm very happy. Okay, so we'll show the slides, the 3 slides that we started the round tables a few days ago, because they show the best how hard is the situation and why we need to talk about it. Gila, next slide. Oh,
sorry.
One.
Yeah, something went away. You guys seeing it?
No.
No.
We see Gila Tolub started screen sharing. Double click. No.
No, still not. Sorry.
No, still not.
Technology always challenges us at the best time, so we'll see.
Okay, but until it comes up, we can say that the war that started at the 7th of October 23 and lasted so far until now is very devastating in numbers. First of all, we can say we have already over 900 soldiers that were killed, 905 actually. We have over 20,000 that were injured, including a lot of emotional and mental health injuries. And we have many of them struggling now with rehabilitation and with the mental and physical hardship. These are numbers that were not known to the military and to the Ministry of Defense rehabilitation wing, because prior to the war, we had a very low number of soldiers recognized as suffering from PTSD, and we didn't have so many wounded soldiers. We had a lot, of course, but not so many. But since the war started in September 23, you can see that the numbers just jumped, and it actually grew by 31% for the physical injured patients, soldiers, and by 180% for those with the mental health issues. And now it is clear that for the Ministry of Defense, that we would have only 45% with pure physical injury and 35% with pure mental health injury, so mostly PTSD. And the combination of the injuries would occur in 20%. So now we're struggling with a very big number of soldiers needing help. And we know that the Ministry of Health, the handicap wing, said in the beginning of the war, a few months afterwards, they predicted that we would have to deal with 50,000 mental health injured soldiers and 50,000 physical health injured soldiers by 2030. But as the time passed, and we've seen the numbers, now the estimation of 50,000 and 50,000 are for the end of 27. So we see it rapidly aggregated and becoming a very big number. And of course, the damage of the trauma injuries are not just physical or mental, it's also with other behaviors. And we can see or expect the suicidality to rise immediately after the war would end. So far, it is not risen, although there are a lot of talks about it. We don't see it still, the big wave has not come, but we know that it usually comes after the war ends, and hopefully now we are at that part, but we don't know that yet. So, but then it would probably grow by 20 to 30%. And of course, 75% of these soldiers would have a higher usage of alcohol and abuse of drugs. We see that as a very big problem and very accumulating problem where over 25% of the population in Israel are now saying that they are abusing drugs of all sort. Gila, next slide.
Yeah, I
Last
just
one
want
for
to
the
say when
introduction.
this statistic of the people saying we're abusing drugs and substances, it's not about illegal drugs, right? It's also Clonex, Xanax, whatever it is. People are reporting increased use of substances, and so
benzodiazepines, cannabis, and we see a lot of them, they use a lot of cannabis to sleep, and then they need to use a lot of Ritalin to wake up in the morning. So it's a very delicate problem. And it's not just the soldiers, it's the circles behind them, with a lot of kids that are now struggling with problems that we didn't anticipate that we will have to deal with, like over 120,000 children with with parents that are not available for over 400 days last 2 years at home. And when we see a lot of children were evacuated, a lot of children were exposed to traumas too, because of the fight with Iran and because of the missiles that were coming all the time. So, and we know that it damages their ability to learn, to function, and to behave. And we have over 100,000 reservists coming home now, and the spouses or the husbands of these reserve force people, they lost their place at home. They don't need them at home, they say to us. I had a very sad talk with the head of the organization for the spouses of reserve force personnel, and they said over 400 days, last 2 years, they have not been at home. They don't know the kids, they don't know the home, they lost their place at home. We don't need them actually, because they come and they need attention and they shout very easily and they don't enjoy the time with the kids, and the kids don't know them anyways. So it's better off that they are not coming back. We can struggle alone because we are already used to it, and that's a terrible state. So they come back home, they don't have where to come at home and where to come to at work usually. And this is a big struggle now when everybody's coming home. So these are the struggles, the mental health struggles and the physical struggles that we'll have to deal with. Gila.
No, thank you, Eyal, for taking us through the latest data. And I think that helps us understand the urgency and why we really need to work together, and the work can't wait. So I want to start with the point that everyone agreed on at the roundtable, and that is that the system is extremely fragmented. It was really obvious. And Avi, I'd love for you to describe what the fragmentation looks like in practice when soldiers move from the army to civilian life, which is your specialty.
Yeah, thank you so much, and thank you for the opportunity. The soldiers leaving the army, we have the active duty soldiers, first time stepping out, and the reservists, each one with its own challenges. One of the main one is the quiet that you get when you finish the service and you need to deal with the quiet, and many things come up. The soldiers usually tracked by the IDF and various programs while serving, and when they're going out, the information about them is not given necessarily to no one else. So if they are proactive, most of the time they should be proactive. They can find different programs that can help them. What kind of a program they choose to go to, it's based on many time location, availability, that their cousin knows somebody, not necessarily what they need. Also the definition of where they are in the spectrum of injury, that it could be like Professor Brown is here and told me many years ago, between 8 to 15% of soldiers will suffer from PTSD, anxiety, depression, and the numbers right now, it's in this bulk of range. And when you think about the 85% who are okay and need further treatment, what treatment they need? Do they know that they are not sick, that they are able to go out of it? All those is not in any type of order by nobody.
Thank you very much, Avi. Now, besides for the fragmentation, it was heartwarming to see the enormous, goodwill. Like today we see hundreds of organizations. We've mapped at ICAR close to 400 organizations, but it creates confusion. And Eyal, I want to hear from your experience. First, why it has been so difficult to build a smoother transition or bridge between the IDF and civilian systems? And also, what are the risks that come with this fragmentation?
So I'll start with the risk from this fragmentation. The risk is, of course, obvious. A lot of people would fall between the cracks because they had therapy or treatment in the military, and if it's not passed well to the civilian life, it's a different, in Israel, it's a different insurance, okay? Unlike in the States, where the insurance of the ex-soldier goes to the veteran affair, and the veteran is very directly attached to the military, to the DOD, and once you have been a soldier and you get released and you need treatment, you get it for the rest of your life. In Israel, after you finish the service, you go and start to work and to become a civilian, and while you are a civilian, you go to Kupot Cholim, okay, which is
HMOs. It's our HMOs.
Yeah, a different insurance. So this means that you can't pass the medical material well. You usually don't get more than a short summary of treatment in the good cases and none at all in the worst cases, and it is passed by the soldier if he is willing to pass it, okay, and sometimes they don't want to pass it. So we are having a lot of computerized difficulties, and the records of psychiatry and mental health are usually very, very hard to pass. There is a great fear from passing the medical data, even between the HMOs to the hospitals, if you're hospitalized, not to say from military to the civilian world, and vice versa. So a lot of the times we don't know in the military, you don't know if somebody was treated before, and you definitely don't pass it after. And it is all based on how well the patient wants to move the material and to pass the knowledge. So that's basically the big problem. And beside that, there is a problem with taking care of the families, which we will talk a little bit more in details later. But again, the family is not treated by the Veteran Affairs or the DOD as in the United States. Their treatment, all their treatment is coming from the HMOs. So you don't have any direct connection. And sometimes they get some help in the military, but there is totally no direct connection about them with the civilian world.
Yeah.
Can I add something?
Of course.
Yeah. Look, I think that one of the reasons there is so much fragmentation is also that philanthropy has been very forthcoming, and lots of new organizations claiming to have the solution to trauma. It has it's unbelievable how many organizations you did the whole list of it. And philanthropy has not really been advised well of how they should help us. Another problem is that we know that the treatment of veterans with PTSD is in the world, with all the evidence-based treatment, is not very successful. So people are looking to find solutions, and then all kinds of organizations come up and say, come to us, we have the solution. I doubt that that is true, because that is really one of our passions, to find more effective treatments, or to combine and second line treatments. So there's a lot of lack of clarity of what actually should we do.
Yeah.
What is a good evidence base for treatment of veterans? It's not so clear in the whole world.
No, that's very true. And I think what you're basically highlighting is that with fragmentation comes the risk of quality standards, which are not established in Israel, as in other countries. But anyone can start an organization and starts to say that they're treating trauma. Very good point. Now, one key challenge in the current system is that those who most need help are often the least likely to seek it, and especially when it is so complex. We just run a survey at ICAR on what drives to help-seeking behavior. We'll do another webinar to share that. And one of the things we saw is just knowing where to go was a very big determinant of actually asking for help, right? So, Avi, I would love to hear from you your idea of how to reach soldiers and reservists that need support. And someone said at the roundtable, it has to be human-led. We can get another SMS, but the scale makes it really difficult. So I'd love to hear from you about examples of outreach programs that maybe are more personal or trustworthy. And I know you're starting a pilot with the municipalities. Would love to hear more about that.
Sure. Also about what you just mentioned about the privileged soldiers who has the capacity to go to programs. There are many programs that if you want to go to, you have to take day off from your work. And many soldiers doesn't have this privilege. So I believe that to keep tracking, we need to find, and sometimes it existing checkpoints that the general society already have, and based on that, and with the right short training for the people in those checkpoints, can at least get the initial screening or the red alert for people, and then direct them. People who are chronically sick and they need help, they can get, if they choose to, a lot of treatment. Whether or not it's working or not, it's another question that was raised, but benefits and recognition and so on. The vast majority of soldiers are not sick. They might suffer from A, B, and C, but they are not sick, and they might need some help to improve their life. And the idea that there will be checkpoints, and that we can discuss later, but might exist already in the system sometimes, when they're coming back to a reserve or through the HMOs, can help track those things. About the families that Eyal also mentioned before, we are now working with the Office of Negev Galil and the IDF to establish in each municipality a specific person in charge of reservists in the municipality, and that to take care of not the reservists themselves, but the reservist families as a whole, together with the municipality and the government. And that can be part of the solution and part of the human checkpoint, but it will be part of it. It should be more robust than that.
Yeah. And just to share, I was discussing with Avi this pilot, right, where you will have in the municipality someone that knows who was in reserve, who came back from reserve. But that person, for example, is not allowed to give that information to the HMOs or to others, right? So that person now has the responsibility and can't share that responsibility.
Under the Israeli law, a government entity who acquire data about somebody, it should be based on law that they have the right to get this data, and they are not allowed to pass it to another government entity without a specific law that letting them do so. It's not like the government holds the data and they can share it with each other. So it might be that Social Security know one thing and the IRS know another thing, and your HMO knows another thing and the IDF knows another thing. They not necessarily share it. So we're trying to find a way that part of the data will be given from the IDF to the municipality. And medical data, it's even more problematic.
Yeah. One of the most emotional parts of our discussion during the roundtable was about families and how invisible they still are. When we surveyed some of the participants, we had about 30 NGOs that joined, and 22 of them actually responded to a survey with pre-work and told us about what they're doing. And actually only 40% of those mentioned even families, right? Many, 60% of them didn't say a word about families. Eyal, why do you think that family support is underdeveloped in our current system, and how can we shift that?
Historically, the military knew how to treat the spouses and sometimes even give some family therapy for people that were working in the army. So these are not mandatory service soldiers, but those who are employed by Anshe Keva, employee of the military. But it took a lot of time before the army agreed to treat them, and only on special programs like the commander that is a fighting commander. So just for special places of people that influence their marital problems. And if you wanted to take care of their kids, you need to show that the kid's problem is connected to the fact that his father or his mother are in active fighting duty for a very long time, and commanders, and that is why they're not at home to take care of the kids. So it was not working too, it was not in full volume. In the DOD, the rehabilitation and handicapped wing in the Ministry of Defense, it took a lot of arguments to change whom we are talking and whom we are treating. And before the war, what was agreed upon was that the spouse of the soldier that is recognized as a handicap due to mental health issue, he would be treated, so the spouse can also be treated, and the kids over the age of 3. And there was a big struggle in the Knesset, in the parliament, about the kids that are under the age of 3. But all in all, the ability to treat the kids and the families, we knew it's important, but it was relatively sided, and we preferred to send them to treatment in the private section or in the MHOs, because these are their insurance. As well as we don't treat their physical problems, okay? Even if it was connected somehow to the stress because the spouse was at the fighting zones. So when you are not used to do things, war is not a good time to gain new habits. And although it's very logical, and everybody agrees that it is logical, it is very hard to build systems that know how to take care of the woman or the spouse or the man and of the kids. And it never ends, because actually the family circle is much broader than that. What about brothers and sisters and parents, and sometimes grandmothers and grandfathers? So it's moving in circles, and it is not in the focus of attention because there are so many new soldiers to treat that you tend to skip those who are not that in the center. Okay.
Yeah. Yeah.
I want to add to that just a little bit. The idea that reservist soldiers will leave their home for 300 days and more changed the map, and some organization understood it better before the others, but the ecosystem wasn't there. I believe also about the new program that we are doing, that the army somewhat stepped a little bit out of its own regular domain, has to do a lot with push that we got from America, from federations, the JFNA, UJA, that from early on said this is an issue in the culture in Israel. Initially it was, you're a wife or a reservist, you are a lioness, you are a very strong family, you can make it. And the reality was deteriorating as the war continued. So it's a lesson for the Israeli society about the importance of keeping those people, and they are not half of the population. If you're talking about the combat reservists, it's a very small percentage of the population.
That's right.
And what more we learned is that today the soldiers, the reserve force soldiers, they have many kids. They have much more kids than they used to in the past wars, both because there are more religious Jews that join the military, and because the population in Israel tends to have a lot of kids. So you have more children of affected parents than in any other war in the history of Israel. So the understanding of the problems of kids and spouses is growing, but it's growing slowly.
Yeah, the
I
number
want
of
to
orphans.
add,
Yeah.
you know,
Go ahead,
it seems to me, and I'm very worried about that the public knowledge about PTSD, that it seems that the cutoff score seems to be floating. And now, if you say to your family physician, I have nightmares, he easily will say, PTSD. My fear is that, you know, if enough people continue to say that, psychiatry will have to give in. And then you will have this, you know, as people say, the tsunami of PTSD. At the same time, of course, it's not all or nothing. There are so many people with what a psychiatrist would call subclinical. If you miss one symptom in order to get the full-fledged PTSD diagnosis, it is not considered anything. So we have a whole issue with that, and in our groups that we're doing in Masashichui and Peace of Mind, we see so many youngsters now who come to us and say, am I getting PTSD? Because the whole environment says that now I have to go to treatment. So there's a whole public awareness issue that needs to be looked at.
Gila,
Okay.
may I follow up on that? This is Sharon Rothberg from the United States. Is it possible or everybody's pre-scheduled?
Yeah, go for it. If you have
Okay,
a question.
so a couple of things. First,
You went on mute.
thank you. I've done reunification programs for the U.S. military. I've supported the VAs here, but I want to take it back to something very simple because I'm not a psychologist, but I wrote the first AI study in artificial intelligence to impact the mental health of stage 3 and stage 4 cancer patients, which was published. But I want to take it back to single mom going through a divorce, misdiagnosed for 6 years with cancer, finally diagnosed with a small child. And my first chemo treatment, I threw a chemo comedy party for everyone in the hospital because I used to book the comics for primetime TV. When I saw the impact that this disruption of humor had in the cancer ecosystem, that night I went home and started the Comedy Cures Foundation. And what I've been asked to do is everything from the first therapeutic reunion for the families of September 11th to launching the first camp for children of terrorism from around the world, to research studies, to reunification programs. I've done a couple programs in Israel, but just because people heard I was in Israel and spontaneously asked me to do military programs or hospital programs. I want to suggest a few things. One is that instead of focusing just on the returning military, it feels like it would be a really interesting idea to focus on the whole country so that in one public service impact, we first normalize this for the entire country. And again, because I started through bringing therapeutic comedy, that, I mean, it's a brilliant way to take away the stigma. The second,
Yeah, Sharon, I would say, like, in general, we are very much thinking like you about a population health approach. Just today, the roundtable is about, soldiers because of the roundtable.
course. Yeah, I'll focus it. So something that I think could be incredibly effective is a pilot study that we did where in 8 weeks, digitally, for almost no cost, we reduced the depression of stage 3 and stage 4 cancer patients over 18%. We reduced their stress over 15%. We reduced their anxiety 10%, and we increased their self-empowerment 8%, with scientists studying, and it was all done digitally during the height of the pandemic. In our second study, where we used a live person, but again, all digitally, we had even more significant results with improved sleep, decreased pain, I mean, increased activity. So these are programs that could be up and running for almost no cost. That where the first one we used artificial intelligence because we didn't have the amount of money in the grant, and it proved to be super effective. So I wasn't planning to speak. I was just invited this morning to show up here. But I had actually approached an organization in Israel, and I said, I think the pilot studies that we've done in cancer in mental health could be incredibly helpful, but just our history with the reunification programs of 3 generations coming together to improve the communication and the reconnection immediately upon return for the children, the parents, and the grandparents. I think it could all be really interesting.
Thank you so much. What I suggest is, why don't you send us some information on, you could send to info@icarcollective.org, and we'll take a look and share here with whoever relevant. It's a great idea. I do want to get us to the solutions part, because we spoke a lot about the problems, and I think we could talk about problems for 2 days. Plus, you know, we love whining and complaining, but I do want to you to hear about some of the ideas that came by having, you know, 30 organizations in the same room, 50 people that are passionate, and we'd love for you to hear a bit of what came out. So we'll start with Avi, maybe, if you could share some of the early actions that you think would make the biggest difference.
Yeah, so several things that came out from the roundtable that I took, and I would like to share. One is the idea that even when you put down a map of showing which organization, where you're located, that the definition, if you are a resilience building organization, if you are a therapy organization, rehabilitation organization, screening organization, where are you? And that the definition will be clear also for the soldiers who knows what they can get, and also for the organization to understand what they claim to say when they say we are doing therapy. What kind of a therapy? Is it a therapy and such? This is one. B, we understood in the roundtable basically that it will be very hard, close to impossible, to right now deliver knowledge from entity A to entity B, and also within NGOs, the idea that you hold data, medical data about somebody, to pass it on to someone else, it's ethically and legally challenged. However, publish aggregated data that you, not on a specific person, but on a phenomenon that can help others to redirect themselves, much more possible. And we don't do that as well. And when passing data or publishing data, aggregated data, the idea that we will all have a standard questionnaire that we understand what are we asking, what can be derived from it, and compare and share, speak the same language. Maybe one day we will be able to share the data, but at least that the different entities in the government and outside of the government will speak in the same language, can be a beginning of a solution. And the idea that I mentioned before of checkpoints, we have in Israel something called tipat chalav, drop of milk, which is a kind of an Israeli invention in the 50s, that every a baby is born and then go to different checkups, mandatory in his HMO and with his mother, and it assisted Israel to reduce baby death dramatically, and also find problems that it's better to treat them while you are very young easily, and get all the vaccines needed and such. On top of this, the Tipat Chalav said, you know, the mother is also here. We can ask her stuff. We can find depression of birth and stuff like that. So the idea that we have Tipat Chalav for babies, we can adopt and say, we want a Tipat Chalav for reservists. You go home, your HMO, you go to your doctor to do a blood test, whatever, he will ask you several questions because you are here now. And let's say that he needs to do it twice a year, and you will come with your kid. He will know that you are a reservist, and you come for your kid has a fever or whatever. You come and he will say, you are a miloimnik, right? I see here that you didn't fill out this form, and ask you those questions. If the doctor will get, as the Professor Bro mentioned before, a little bit of training to understand what is alert, what is fine, what needs to be keep track, and this information by the nurse, by the doctor, whatever, will go to already existing, to my understanding from the roundtable, in many cases in the HMOs, already digitalized and systems for mental health. And that way we can have at least kind of a tracking, and I'm talking about screening, tracking, not the treatment, not referral, that this is another issue, but it's a beginning that can reduce suicide, can reduce maybe development of mental issues, and refer to treatment.
Thank you very much, Avi. Eyal, would love to hear what you took away of the from the roundtable about, what are some of the actions that could make a big difference today?
I think that.
Wow.
Sorry?
Go for it.
Okay. I think that I took several things from the roundtables, but I think the most.
There's very few people on here.
We need to mute Simcha.
Yes.
Okay.
I think that most of the most important thing was that the different points would connect to each other, and as Avi said, would have the same questionnaire and the same reference of knowledge, so the diagnosis would pass, and so we can see the continuum between what happened in the military and outside the military, and in the transition points. And if this would pass clearly, we would, for the first time, have a longitudinal ability to look at the soldier and not fragmented kaleidoscopical sight. The other thing that I think would very much help, and I know that there are several places it's going like that. I heard today about the mental health in Wales, and I learned that in Wales, you have the same therapist in all the points. So if you are hospitalized now, he's catching up with you, and he's moving with you to all the stages of rehabilitation. And I think that one person escorting you is super important. The fact that families and injured soldiers with mental health problems need to find new people on the way, and of course they need to meet a new psychiatrist, but somebody that will escort them all the way is super important. Today you have the mental health officer in the military, and then you have in the transition zone, and then you have a new one from the Ministry of Defense, and a new one if you go to the HMOs, etc. And you need to readjust all the time, and they're not adjusting very well, and a lot of data again falls between the cracks. So I think this would be the most important.
Thank you so much. I'll also share a bit of other ideas that came out of the roundtable, so you guys have an idea of what was discussed. Two things. One was the quality standards that actually Danny mentioned earlier. A lot of people said, look, I'm not going to be comfortable using any org or referral pathways unless we have quality standards that we all agree on, and that I know that if I send that patient to you or to an NGO, etc., will work. And another thing that is a little bit of a dream for everyone is to think about some kind of algorithmic matching. We have Shani Sofer, the CEO of Invisible Album, with us, and she's built a platform that helps soldiers find programs, and it's based on different filters and their preferences. I think there was a long discussion around, could we collect some data about the soldier and actually help them pick what is best for them based on the data, right? What do we need to know about the service provided by each NGO or each organization? And what do we know about the soldier? And how do we do that smart matchmaking? Because right now, when a soldier needs help, he gets a list of 15, 20 places, and it's up to him to call every single one of them and to figure out what works, what doesn't work. And that's not extremely helpful. We got a few questions in the chat, and so I'll start with those, but please keep them coming, and please raise your hand if you want me to come to you. We got a question about predictive analytics, and I guess I'll ask Avi and Eyal. let's stick to the army, right? And the soldiers. Is there any work currently on doing any predictive analytics to know early identification of who's going to need help, and how do we catch them early? And Danny and others on the line, if you guys know about something like this, let us know, because I think we're not there yet.
To my knowledge, the predictive is by the population by mission, meaning combat soldiers have more chances of getting, and it depends what kind of a combat you are, and the other population also has to do with watching screens and stuff like that in the intelligence that are at-risk population. To my understanding, the fact that somebody seems strong physically, mentally, in training, and very proactive and fighting well does not predict how a specific incident will, what impact it will have on him, and maybe there are, I'm not aware of.
Yeah, but we know that if the trauma was very, very bloody with a lot of casualties, then the risk is higher. If you were not from the team that was hit, but you were a part of them when the hit happened, so you were not with your original unit, or you are an escortee, like, you know, those who go from Ockets with the dogs, or you are a drone manipulator, and you are assimilated to a group, then you are in a higher chance of developing a problem.
Yeah, but are we doing anything with this knowledge? That's my question.
Oh yes, we do a lot with that.
Predictive analytics? Are we saying like we should check on these people because they were in that situation?
In the
Yes,
work
we learned about
do,
that. Sorry, Avi, go.
Just to say quickly, in the work that we do, the IDF know to say this group considered to be a red group that needs specific treatment based on what they went through. That's what I meant by the mission, not to predict specific person.
And that is a very limited way of looking at risk, because risk for PTSD is a very complex issue. It has to do with previous trauma. It has to do with social support. It has to do with exposure to some degree. It has to do, for example, with some of the things we don't know to do anything about it, but the intelligence, IQ is a predictive factor, but you're not going to measure that before people go into the army. So there is a...
Actually, Danny, this is what we check. We have the DAPA, which is a correlate for IQ, but you do not choose for them a unit based on that. So
exactly.
But we don't check their backgrounds. That's true. Yeah, sure.
So it is a very complex issue, and it does not, really replace the issue of checking, screening, and making sure, and that is what we do again in the Peace of Mind program, where they fill out questionnaires before and after and follow up, so that you can then see who needs more. And if all the organizations would do that, would be in a different place.
Yes. We actually have a document for anyone who wants about the metrics that every organization should be tracking, and for funders also what metrics they should be asking of the organizations to track. That includes what Danny's talking about. I will also mention a piece of research from 9/11 that has tracked first responders for 20 years. In there, they showed that the severity or the ability to recover was not linked to the severity of the trauma on the day of, or the exposure. It was much more linked to the coping mechanisms, to the support systems, to the community, etc., which in a sense, to me, gives me hope, right? Because it means that if we do things correctly today, we can really influence the recovery. It's not set in stone that if someone was in a terrible situation, they will suffer for a very long time. you had a question as well, Alon, about do we know from the unit? So, the Israeli army actually does not track PTSD or other issues by unit. I actually was at an event where a unit said, "Hey, we're the unit with the most PTSD," and I'm very curious. So I said, "Really? How do you know?" And actually, it's more of like anecdotal evidence, because the army doesn't track, what units are more affected or not. But I think it would be interesting, and I don't think it would be that complicated. We have another 5 minutes. Anyone wants to raise a question and take advantage of being in the screen with us to speak up?
If I may add to what you just said, I think that the system in Israel, the army would not know, especially with reservists. We did whatever we did. It could interject 10, 15 years later. And then you would either go to your HMO or you go to Natal. And that would never be sent back to the army. So I think that for many years, the army had the illusion of we do not really have these numbers of PTSD. In many ways, I think this is the first war that we actually openly talk about it. And we talk about the impact in the families and at the workspace. And even that is not the long-term PTSD. It's more like, how did you come back from your long reserve duty? And what did you see? I think we do not know yet about the impact of what happens later. And that data collection is something that maybe we should address now to bridge these gaps.
That's right. Murray, yeah, go for
Yeah,
it.
just a general comment. I mean, obviously, this issue is so profound and pervasive and important, and putting our heads together like this is really quite something. And essentially, building the plane as you're flying, and the imperative to get it right and to come up with something new and synthetic and best practice is so important. And not just for Israel. I mean, worldwide, this is going to be tremendously important. And I think from everybody's work. Again, Israel will become the leader in this field. So the imperative is quite strong. And again, I am just so in awe of all of the work that all of you are doing. So thank you.
Thank you. Mirom, I see your hand is up. Yep.
Yeah, I have two thoughts I'd like to share. One is to also look at, Yochi and I run a business psychology executive coaching practice. And we're seeing the impact of PTSD on many of the executives that we're working with that run international businesses from Israel. And so I think there's an avenue, Gila, for you to talk about with investors, with executives. I mean, we're seeing it impact, and so there are places where you could be addressing this there, and a perspective from a serial entrepreneur. When we sold our last business, we came as Olim to Israel, and and we learned that the practice of psychology and these issues of PTSD and building courage and building resilience, the practice of that in Israel is different from what it is in the US. And in many respects, you're way ahead of what the practice of psychology is on this side of the ocean.
That's right.
And there's also a healing power in being able to teach what you've learned to others. And we see in executives being able to teach what they've learned to others that haven't gone through the trauma. And so I just want to share those thoughts with you, and hope it's helpful.
Thank you so much. I mean, it's a great reminder, right, that we often look at all the problems and we don't realize that Israel is very advanced on a lot of these topics. You know, we complain about lack of data interoperability, but on the physical health, we're better than the whole world. And so we will get there. We are at time. And I will say that just like today, the roundtable was really a magical time where we see what becomes possible when we're all in the same room. Someone said at the roundtable, you know, we're all tired, but at least now we're all tired in the same direction. And I love this because that shared fatigue, that shared alignment tells you about where we are in the process, which is, you know, collective effort, optimism, you know, next to realism. But the need for persistence, the need to understand that the end of the war does not mean the end of the needs, especially when it comes to mental health. Actually, there's a lot of research that shows that the end of the war is only the beginning of the healing process. And so we need continued collaboration. And so really, thank you for joining us. And if anyone wants to join the you know, our working groups on soldiers, do let us know. Thank you all.
Kol hakavod. Kol hakavod. Thank you.
Thank you so much.
Bye-bye. Thank you.
תודה רבה.
Bye.
תודה. ממש תודה.
ביי, אלון, תודה.